over distension of levator and muscle fibers, which we call for ballooning. When we do the ultrasound assessment of the levator and the muscles, we always start at the mid-sagittal view. Here you see the ultrasound image of the transperineal ultrasound probe being placed to the perineum, where we can see the symphysis pubis, the urethra, the vagina, the rectum, and the levator and the muscles, and the urinary bladder. So when we see all these structures, we are in the so-called mid-sagittal view, which here you see it is a perfect view of the mid-sagittal view of the pelvic floor. Here is our start point for further assessment of the pelvic floor function and dysfunction. So first what we can assess is the pelvic floor muscle contraction. Again, we find the mid-sagittal view, and during the contraction, we ask women to contract. It means that she lifts her pelvic floor muscle, and we look at the distance between the symphysis pubis and the puborectal muscle. If woman contracts, this distance has to be shorter, and this distance corresponds to the minimal hiatal distance. So here we ask the patient to contract, and we see that she's lifting her pelvic floor muscles, and the distance is being shorter. Here is a short contraction, but it's normal contraction. And here we see another patient of the contracting. Again, we see that it's the distance between the symphysis pubis and the levator and the muscles is becoming shorter. Here is a visually stronger contraction that lasts longer. Again, we see there are two patients with contracting pelvic floor. Contraction is important because we're going to assess the levator and the muscle integrity during maximum contraction. During Valsalva, we ask patient to push, which means that the distance between the symphysis pubis and the puborectal muscle will be larger. These structures will be further apart during the Valsalva. We ask women to push, and here you will see a small Valsalva with short push without any organ descendants. We ask women to push, and we see that she's pushing. It means that structure is going down. We particularly look at the urinary bladder and also at the rectum and probably even small bowel. Sometimes may protrude here. Here is a normal Valsalva. Here we have another patient, again, symphysis pubis, levator and the muscle. Here is urinary bladder, urethra, and here is rectum, and here is the levator and the muscle. So look what happens to the rectum and to the urinary bladder when we ask women to push. We see that the urinary bladder descends below the line, below the lower line of the symphysis pubis, and also the rectum is becoming much lower than this line. It means that this patient has cystocelia and rectocelia. Some patients, when we ask them to push, they contract instead, which is called for coactivation. So here we ask patient to push, she's contracting because the distance becomes smaller. And thereafter, the patient is pushing and then again contracting. We call it for coactivation. When we assess pelvic floor muscles, levator and muscles, we need to use 3D 4D ultrasound. And thereafter, we need to work with the images with either manual post-processing or using automated or assisted post-processing. In order to obtain the pelvic floor muscles, we need to start with 2D ultrasound, but with the help of the ultrasound equipment and the software, we get the 3D ultrasound, the coronal view. This coronal view is generated by the software, which is installed in the ultrasound machine. So in this coronal view, we see the following structures. We see the urethra, the vagina, the anus, and the levator and the muscle that is attached to the ramus pubis inferior, which is here. So here is the puborectal muscle attached to the ramus pubis inferior. This is a normal coronal view. When we acquire the volume, a system generates for us 4 images. So first, the first image is the reference image, is the mid-sagittal view where we start our image acquisition. Thereafter, we get the generated image 90 degrees to the first image. And then the coronal view with the rendered mode is generated by the software. and it's called for multiple rendering. So how does it work? What we're going to look here at. In order to obtain a normal coronal view, as I've shown you previously, we need to be familiar with the reference line. So reference line is the line that is a line that is drawn through the lower part of the symphysis pubis and the levator muscle in order to obtain the perfect view. So this line is as a window for us. It means that everything what is just below the line is shown in this and this image. So if we have the line not in the appropriate level, we will not be able to see this image. And in that case, we need to work manually with the image post-processing or use the automated software as pelvic assist. So here we see the line is at the perfect level, but here is just the acquired volume where the line is not perfect level. The line is too high, therefore we do not have any image here. So what we need to do is we need to move the line. We can do it manually. So we activate and move the image around in order to place the line. We have to rotate the image a little bit. We see that the line is still not appropriate, but almost. Then we, of course, we can reduce the box, the rendering box, and put it at the appropriate level. And in that case, we get the coronal view of the pelvic floor, which we can further assess. So again, we can do it either automatically or manually. So for us to assess the levator and muscle integrity, it is recommended to assess it using multi-slice view, MSV. So for multi-slice view, again, the system generates us 9 images. First image is our reference image with the reference line, which is purple here. We can see that this line is drawn where the distance between the symphysis pubis and the levator muscle is the smallest, which is the narrowest hiatus. And thereafter, we use the 2.5 millimeter distance between the slices. And we see every slice is corresponding to the image. Of our particular interest are these 3 images. So the image in the middle is the one that is this purple line. And all other images from one side to another side are 2.5 as further from it. We look at these 3 images and we assess the attachment of the levator and the muscles to ramus symphysis pubis in these 3 images. What are we looking at? We're looking at all these 3 images and see if there is any defect between the levator and the muscle and the ramus pubis inferior. As we see here, the muscle is attached, there is no defect, and when muscle detaches, we can see that there will be a defect. This is the detachment of the levator and muscle. In order to quantify it, it is recommended to measure the distance between the urethra and levator and muscle. So here we see how the measurement is performed. We measure from the mid-urethra, middle of urethra, to the insertion of the levator and muscle. And if this distance is 25 millimeters or more, in these 3 slices in the middle, in at least one side, it's called for complete levator and muscle avulsion. If the distance is larger than 25 millimeters in 1 or 2 slices in the middle, it is called for partial avulsion. Again, it is important to remind you that the assessment of the levator and muscle integrity should be done during maximal contraction. So again, I'm going to show you how it can be done with the manual post-processing, using multi-slice view. Here we need again to adjust the line manually and activate the multi-slice view. And thereafter, we need to rotate the image again manually with 90 degrees in order to obtain the coronal view and do some small adjustments by the rotating of the image and selecting the appropriate level. Here we can see what is the appropriate level. The appropriate level is, go back to the previous image. The appropriate level is this level where we see that the ramus symphysis pubis is open in this image, closing in the middle image, and closed in the 3rd image. So if we do it automatically, the system helps us to find this correct level, and you can use for it pelvic assist, which is integrated in the ultrasound machine. And again, we find the mid-sagittal view, activate 3D ultrasound, and they press the button for pelvic assist, and the system generates the image and finds the correct level for the reference line. And you can see here that in this image, we are perfectly in the open, closing, close level of the ramus symphysis. And of course, the system may follow the patient. If patient will move muscles or contract, the line will be aligned automatically. So you will always be at the correct level. So now I'm going to talk about microtrauma, about the ballooning, which is again irreversible distension, over distension of the levator muscles. And this is something that we assess during maximum Valsalva. So hiatal area is assessed during maximum Valsalva. So first we have to perform Valsalva. Again, remember what is Valsalva. The patient is pushing, and the structures such as symphysis pubis and levator muscle are becoming further from each other. And then again, we can, to acquire the coronal view, we get the help of the ultrasound machine, and we need to place the line and the symphysis pubis and levator muscle. And after obtaining the coronal view, we measure the hiatal area, which is the inner part of within the muscles. So this area is very important. Here you see the reference values for the normal and abnormal hiatal area. So if it's below 25 square centimeter, it's normal. But if it is 25 centimeters or more, it's abnormal, and it's divided to mild, moderate, marked. And severe ballooning is the one that is more than 40 square centimeters. So again, we can do it measurements manually by drawing the line for the area, but we can also use the automated measurement using the pelvic assist program. Here we see the area, and we see the result of 17.5 square centimeters. And here it is done again with the pelvic assist, which is again, pelvic assist helps us to find the perfect reference lines and generates the hiatal area and does the automated measurements for that. So now I'm going to show you how it is done in real life. We have the video, we have the mid-sagittal view, first adjusting to be sure we are perfectly in the mid-sagittal, activate 3D and activate pelvic assist. And thereafter, you will see that the line is dropping in the correct position directly. And here is the, again, the patient, we start Valsalva, it's very small Valsalva and very normal area of 17.5 square centimeters. We can also, if we find that the system does not 100% correctly define the hiatal area, we can also correct it manually. As you see here, we can activate the line, and in this case, it's normal. However, just to show you how it works, we can draw and we can adjust the line in order to get it placed correctly for the area, and go around and do some manual adjustments after that. And here again, we have the Valsalva. Another patient performing Valsalva, and she's pushing and a bit contracting at the same time. And we see here the line is very high and very incorrect. Pelvic assist directly aligns. And also after that, we ask for measurements, and it will measure the hiatal area. And if you see that this line you don't like, it's probably not correct for your eyes, you can also, again, adjust it manually, which probably does not change that much the result. But here we see that the area is 33 square centimeters. And here again, we see a patient with normal hiatal area, which is measured with the automated pelvic assist system. And here we see a patient with the large hiatal area, which is also measured with the help of the system. And we can see that again, manual post-processing, it's possible. Here I'm going to show you again one more patient with the hiatal area measurement using pelvic assist. Again, we activate mid-sagittal view, we activate 3D pelvic assist, and the line is originally very high, and you see that you do not see anything, and what is pelvic assist doing, and it helps you to align. to do the live alignment and also finding the appropriate level, and then again to do the automated measurements. In this case, we see that these are normal 23 square centimeters. So now I've shown you how to important to find and to detect levator and muscle injuries. First, it's quite common. It affects both avulsion and ballooning, about 1 in 3 women after vaginal delivery. And it has been shown in a systematic review that pelvic organ prolapse was the most common disorder in women with levator and muscle avulsion. And there was also some association with sexual dysfunction. Ballooning is also very important to detect because there has been shown strong relationship between the pelvic organ prolapse symptoms and hiatal dimensions at rest and Valsalva. And also in this retrospective study, levator and avulsion was found in 1 in 5 women, and hiatal area was also measured and found in and it was found associated with the overactive bladder, urine stress incontinence, and also pelvic gonoploxan found in about 1 in 3 patients. And again, large hiatus is important because it is observed in women with levator and muscle avulsion and pelvic organ prolapse. If the hiatal area is very small, it may be associated in women with stress incontinence. And also, that has been observed that avulsion and ballooning may be associated with prolapse symptoms, and these are 2 independent risk factors for symptoms and signs of pelvic organ prolapse. So today I've shown you how you can use the ultrasound in order to assess pelvic floor. I've shown you that there are 2 types of levator and muscle injuries, microtrauma and microtrauma. These can be detected at ultrasound. An automated image post-processing with the help of pelvic assist will facilitate your ultrasound assessment of deep pelvic floor muscles and will help you in your daily work. Thank you so much.
Birgitta, thank you very much. Actually, this was such a nice, clear presentation. So we don't seem to have any questions from the audience. I don't know if any of the speakers have anything to ask. I'm just interested. I mean, obviously, you're describing, an AI tool in effect, and this, this session is about latest innovations in gynecology. So, do you feel oh, hang on, here we go. I'll just ask you. Well, I'll ask you my comment first of all. I mean, do you feel that for most users, how often do you have to correct the? Do we want to stop sharing, Samsung? So we actually talking to speakers. That'd be great. How often do you have to correct it? Because I think if you're not very experienced and you say you want to rely on the AI tool to generate the appropriate planes, it seems to me that you still have to have the knowledge base and experience to recognize that it's not correct, if you see what I mean, and therefore correct it. So at what point do you think it's going to be good enough that you can effectively not have that knowledge and rely on it? Does that make sense?
Yeah, I think that makes sense, absolutely. So first of all, these AI softwares are very useful because it enables the learning process being much faster. But this is the same as for image optimization when we use a 2D ultrasound in general gynecology. If we do not know how to optimize the image and we use only preset, we of course are not able to make some corrections and we are missing some details in the image. So I think to know the basics and to know to wait to the image post-processing is very essential. However, it's quite a long time that requires to learn all the process. So people that want to do pelvic floor, they feel and experience it quite complicated. So for the AI tools enables us directly to find the correct plane. So we don't need to do many steps in between. So this is the first one. And then secondly, of course, we need to do small corrections. For example, if you do hiatal dimension, if we have particularly women with a prolapse like cystocele or rectocele, and we have wide hiatus, sometimes the system, because of the artifacts, cannot find the very exact contours, and then we might need to some corrections. But for the image, for the planes, I have not experienced a huge need for the plane correction, because if you use the automated alignment, The system will be following, and if the patient will move or contract or release the Valsalva, the system it will still follow the line and to identify this is automatic alignment. Live alignment is very useful for that. If it would be not live alignment, again, we need more post-processing. We need more steps to get the right plane. But the live alignment helps a lot. So I think this is a very good tool, and I think that more people would be able to use it because of that. It's very easy. I mean, it doesn't require a lot of experience.
I can see that if one of the things in ultrasound obviously is recognizing the pattern. So if something is identifying it for you, that learning curve is going to be so much faster, isn't it? If it's that's the first thing you said in your answer. I think it's underestimated how useful it is from an educational point of view when you have effectively the distillation of an expert doing it through AI to show you. I think is actually very helpful. Okay, we've got some questions from the audience. Let's start with the simple one. Marvelous presentation. There we are. You have a fan. Can we use a transvaginal transducer translabially?
Of course we can. We
Yeah.
can use transvaginal transducer translably. We can also use transvaginal transducer just at the level of the introitus and get the image. Of course we use, but translabial ultrasound with the abdominal probe is very widely used. But of course you can get very good image resolution with transvaginal ultrasound probe. If you have 3D transvaginal ultrasound probe with 3D function and you want to take the image, just be careful if you don't have a possibility to do the live, like a 4D image acquisition. It will be the limitation, but if you have this possibility, you should be able to use any of the transducers. And of course,
3D is
I didn't say it in my presentation, but you can use, if you want, you can use translabial, you can use transabdominal probe to translabial route, you can use transvaginal probe to transperineal route, and also you can use the transvaginal probe in the introitus of the vagina for the Levator assessment.
and the pelvic assist works the same on any of the probes, does it? Or is it validated on these different probes?
Yes, it should work with any probe.
Okay. Second question here. Excuse me. I think you can read it. Do ultrasound measurements or objective assessment select the operation type for cases? Do you want to say something about that?
Yes, so I talked in my lecture about how to assess levator and MSL injuries, both ballooning and avulsion. But of course, the following question is, so what? If we detect it, what we do with the result? So first, if we can detect, we have several studies indicating that those women that have diagnosed levator and MSL avulsion and ballooning are at a higher risk to develop pelvic organ prolapse. So this is first one. Then when selected the surgery, we also know that those women that have a levator and a muscle avulsion, either diagnosed preoperatively or postoperatively, will benefit more from for example, using mesh during surgery rather than native tissues because of the high risk for the recurrence of the prolapse if we use native tissues. And we also know that, for example, if you use pessary, and in case of the levator and muscle avulsion, there will be high risk of the expulsion of the pessary. So this is what we know. So again, when we select the treatment, we need, of course, more studies, but we know that for those women that have injuries, they are at a high risk for the recurrence of the prolapse. And again, the mesh surgery is more beneficial than surgery using native tissues.
Okay, so I see. So basically, you do get guidance from what you're looking at on the scan in terms of future management. It can triage people appropriately, if you like.
Yes, of course, but I think there is a need for more studies because in order to select the appropriate surgery for individual patient, I don't think we are there yet, but we know that there are risks and there are suggestions how to reduce the recurrence rate. Yes.
Okay. In terms of the assessment of levator avulsion, I mean, what's the best time to do that? You see what I'm saying? I mean, because obviously this happens during childbirth, and I think it's quite difficult to evaluate imaging at that time because it's quite edematous, whatever. But is there an optimal time period you would say I mean, looking forward, if it can become a simple test done by AI, and given the fact that I would imagine still a lot of Levator, this isn't my field, but a lot of this trauma is missed until much later on. Do you see a situation where a simple AI-guided evaluation could be done X time following delivery, and then that would guide intervention? Or is that a stupid idea? I mean, what do you think?
Yeah. So what is the best time? So what we know from the studies, if we compare assessment of the levator and muscle avulsion and hiatus 1 year after delivery, according to the publications, 97% of the results are in agreement with those obtained at 4 months after delivery. So this is one. But we also know that other studies show that the rate of levator and muscle avulsion of course of the ballooning is decreasing with the time. So probably to look to the time after delivery. So if we look very early, like 3 months, we will be overdiagnosed because the hiatus would still be large, and maybe it will be difficult to diagnose, and also the rate will decrease with the time. And there is also a discussion, it could be a spontaneous healing or not, probably not for the avulsion itself, but for the microtrauma, for the overdistension of the muscle. So again, if we wait until 1 year after delivery, it probably be good. If we wait at half a year, we would probably got very similar results according to the existing publications.
Yeah. So again, it's always that issue of knowing the natural history of the disease and sensitivity, specificity. Excellent. I don't think there's any other questions from the floor. I found that absolutely fascinating, and I think really does play into the sort of theme of the webinar, where we're now seeing some of these tools actually changing clinical practice and making, I'm sure it makes life quicker as well. I mean, that's the other thing in terms of patient throughput. It must make things a bit easier from that point of view as well, not just in terms of recognizing the claims. Ligita, thank you. I hope you stay in your dark, air-conditioned hotel room and not going back to the beach at this point, because that makes me feel an awful lot better at the moment. And we'll come back to you later on if that's okay.
Of
We're
course,
going to move on. Thanks so much, Ligita. So we're going to move on to Professor Juan Luis Alcazar. JL, how are you?
Hello, nice to meet you. Nice to everyone. I'm very fine and happy to participate in this webinar.
So for everybody who is not in Southern Europe, Southern Europe is sort of generally being quietly boiled in 40-odd degree heat. However, JL is cool as ever, but due to his overriding coolness, where he is cooled down to 32 degrees. So he's actually okay. Now, Juan Luis is basically does everything. You know, he's a very highly trained surgeon, but he's also been working in advanced gynecological ultrasound for many years, and as most of you will of course be familiar with his publications. But his one of his primary interests, and he's been very much involved in the IDEA consensus, which I'm sure JL will explain. And this is about, first of all, trying to get standardized nomenclature around ultrasound when we do diagnostics, so that if I'm in London and JL's in Malaga, we're talking about the same thing. So if we're doing studies, that obviously is going to make things consistent. And then from there, obviously, how to recognize these features and how they translate into clinical practice. So this is really important. And JL, hand over to you and look forward to your talk.
Okay. Hello, good day. My name is Juan Luis Alcázar. I'm professor of obstetrics and gynecology at the University of Navarra in Pamplona, Spain, and also senior consultant at the Department of Obstetrics and Gynecology in Hospital Quirónsalud in Malaga, and co-director of the Training and the Education Center in Malaga. It's a pleasure to be today with you to talk about a quite interesting topic. Particularly, we are going to talk regarding the scanning by ultrasound endometriosis using the IDEA protocol during the real-time examination. Well, probably all of you already know the IDEA consensus. Published in 2016. This is a consensus regarding how to perform the scanning protocol ultrasound in women with suspected pelvic endometriosis. Probably the most relevant figure of this consensus is this slide. These 4 steps which has to be performed in a sequential way, not excluding one of other, and based on the first step to evaluate the uterus and the adnexa, looking for sonographic signs of adenomyosis or the presence of ovarian endometrioma. The second step for evaluating the so-called soft markers, which particularly are the site-specific tenderness and ovarian mobility. The third step, the assessment of the sliding sign to assess the status of a pouch of Douglas. And finally, the fourth step, which implies the specific search of deep endometriosis nodule in both the anterior and posterior compartments. Step 1, as I told you, is the search of sonographic signs of adenomyosis, as you can see in these 2 videos, and also the detection of the presence of ovarian endometrioma in one or both ovaries. When measuring the uterus, some machines have developed a particularly interesting tool, which is called a uterine assist. This is an automatic measurement of the uterine length, endometrial thickness, uterine height, and uterine width. As you can see in the video, just by touching the screen, you will get the automatic measurements of all these measurements. And it's actually, they use the MUSA protocol, as you can see here, the cervical length, uterine length, the fundus length, endometrial thickness and height, myometrial height, and myometrial or uterine width. You also can observe the presence of asymmetry, and this is a quite interesting issue. Also, some machines have developed the so-called uterine contour, in which you can get in an automatic way the coronal view of the uterine cavity. As you can see in the video, you just touch the screen. The 3D volume is acquired, and by automatic measurement way you will obtain the coronal view. And this is quite interesting to assess the junctional zone in the coronal view of the uterus, as you will see later on. Here you have 2 examples of the coronal view obtained in adenomyotic uterus. If you compare this coronal view by tracing the endometrial cavity, as you can see here, you will see that the endometrial myometrial junction, it's interrupted, is inexistent, actually not visible, and or irregular, as you can see, which are clearly signs of adenomyosis. You can observe these signs basically in an automatic way using these tools. Step 2 is related to ovarian mobility. Here you can see the ovaries, and this ovaries is mobile. This is the left ovary. It's mobile, no additions here. However, in these 2 cases, you will see how this right ovary with the small endometrioma is fixed, is not mobile, the mobility is reduced, which is a clear sign of a soft marker. Here, another example of ovarian limited mobility in these 2 cases. And remember, this is the second step. Actually, the site-specific tenderness is a clinical, actually, finding when you move the probe into the vagina, pushing any part of the vaginal bolt, you will see if you detect any pain point or painful point, this is the suspicious of endometriosis. And then the step 3, which is so-called a sliding sign, you will see here a positive sliding sign in an averted uterus. The rectum slides over the uterus, particularly the retrocervical area and the fundus here. So this is a positive sliding sign, which means that the pouch of Douglas should be free in this patient. In this other case, you have a retroverted uterus, and you see that the uterus, the sliding is negative, and the posterior, the fundus of the uterus is not sliding over the rectum. This is a negative sliding sign, and this means that the pouch of Douglas could be obliterated. And finally, the step 4. In the step 4, we had to look for specific nodules in the both anterior compartment and posterior compartment. Anterior compartments, as you all know, implies the bladder in the trigone, the base, the dome, and the extraperitoneal part of the bladder, also the urethra and the ureterovaginal space. Also, the intramural part of the ureter could be observed. Here you have a nodule in the trigone. Here you have a nodule on in the dome of the bladder, and here you have a small lesion in the base of the bladder. This is the ureter right there. And the posterior compartments implies the bowel with the lower rectum, which is the extraperitoneal part of the rectum, the upper rectum, the intraperitoneal part, the sigmoid, and also the uterocycle ligaments, the rectovaginal septum, and you will see here like a nodule in the anterior wall of the upper rectum and sigmoid, another nodule in the upper rectum involving also the uterocycle ligament here. This is a so-called diabolal sign, which is an involvement of the upper rectum, vaginal, retrocervical area, and uterocycle ligament, and also another nodule here. And all of these are nodules within the posterior compartment. And then the IDEA protocol proposed the use of topographic way to report all these findings when you scan a lady with a deep endometriosis, deep pelvic endometriosis disease. Well, Samsung has developed an inbuilt protocol to follow all these 4 steps, improving the workflow. When you scan a lady, it's like a GPS, which is guiding you to perform this scan in order to avoid any mistake, any forgetting any steps. You see here, step 1, you can observe the presence of adenomyosis, the right or left endometrioma, typical or atypical, also the kissing ovary, which is also a soft marker problem. Then you can measure the size of the lesions, and you also can go for as many as endometriomas could exist. You can measure them. Also, you can measure the ovaries, of course, and then you can follow to the 2nd step, to the 3rd step, and to the 4th step, as you will see. And this is how you see in the screen all the 4 steps. You see here, IDEA step 1, presence of adenomyosis, yes or no, which is our direct signs or indirect signs. You have to mark to observe the presence of those direct or indirect signs. Also, you have the right endometrioma, and you can measure whether it's a typical or atypical endometrioma for the right ovary or for the left ovary. When you go to the second step, then you look for presence or no of site-specific tenderness. You have to click, yes, to mark whether this site-specific tenderness is present or not. Where is the painful point? Is it affecting the ovary, the uterosacral ligament, or either in the anterior or posterior compartment? Then you have to look for the mobility of the ovaries, if it is mobile or not, and it is mobile in relationship to the uterus or to the pelvic side wall, and also not being actually a part of the idea consensus, but interestingly, this tool also allows you to indicate the presence of fluid in the pelvis and also the presence of hydrosalpinx or peritoneal cysts, which is actually could be considered as a secondary markers of presence of adhesions involving the tube or involving the peritoneum. If you go to the step 3, you have to look for the sliding sign, particularly in the anterior or anteverted or retroverted uterus, and particularly looking for the sliding of the retrocervical area or the posterior funda, uterine fundus, and you have to look for the presence or absence of those signs. And finally, you go to step 4, looking for lesions in the anterior compartment, present or not, involving the urinary bladder, measuring the nodules you can see, also analyzing the sliding of the uterine vesicle region, and finally the right and the left ureter. Remember, in the intramural part of the ureter, when you look to the anterior compartment. And then finally, you go to the step 4, looking for posterior compartment lesions. You can detect the presence of nodule in the uterosacral ligament, right or left, or the torus of the uterus, measuring them. Or bowel disease, measuring the lesions in the lower rectum, upper rectum, sigmoid, and also obviously in the rectovaginal septum. And here you will see real-time scanning and the use of this protocol inbuilt in the machine. So we start. This is with gel into the vagina. You see the urethra right there. This is the posterior vaginal wall. This is the anterior vaginal wall. This is the anterior fornix, vaginal fornix. This is the bladder you see here. Forget about this pointer. Actually, this is a anal canal. This is the levator any muscle, and then you see the sliding in the rectovaginal septum, which is this tiny hyperechoic area. So the sliding means that the rectovaginal septum is not involved at all because the sliding is present. So here you see the anterior vaginal fornix, and then you see the uterus right there with a small lesion here, could be adenomyoma. And you see again the anterior vaginal fornix. It is easier to observe that part if you put gel into the vagina. Then we see the posterior vaginal fornix. This is again the rectovaginal septum. And here you see the uterus, looking for sign of adenomyosis. If you see sign of adenomyosis, you have to indicate the presence or not. You see here, yes, then you can detect the presence of direct or indirect signs. Direct signs are small myometrial cysts, for example, or hyperechoic islands. Indirect signs, remember, this is a budding endomyometrial budding here, and also indirect signs like shadowings, fine shadowings, myometrial asymmetry, globular uterus, and so on. So you can put on the screen the presence or absence of those signs. Once another small lesion there, probably hyperechoic area right there, or this other tiny myometrial cyst. You can measure, can record all these lesions when you assess the uterus. Okay, then you measure the lesions. As you can see here, this is probably fibroid, probably adenomyoma. Sometimes it's difficult to discriminate one from the other. And then you look for, here you see the cervix. And again, you see here the bladder. But we are not still at that point of the scanning. We are just recording videos of those lesions. Then you go to the ovaries. Remember, we are still in step 1 here. You see the ovary with this corpus luteum, a small follicle there, and you measure the ovary. Okay, you assess the mobility of the ovary also, and as part of the step 2, but still you are measuring the ovary here and looking for the presence or absence of endometrioma. We are measuring the ovary here, as you can see, and then you measure the corpus luteum also. In case you observe any endometrioma, you can establish whether this endometrioma is a typical endometrioma or atypical endometrioma, and you can measure the size. Actually, you can calculate the volume of the endometrioma. Is measuring the corpus luteum, the hemorrhagic corpus luteum. This is the left ovary with the follicles, and then you can measure the ovary. If you see there is no endometrioma, you mark no endometrioma, as you can see here. And then you measure the ovary like this. From here to there, the length and the height of the ovaries. Okay, so we are done with the step 1. We move to the step 2, and then we are looking for site-specific tenderness. If you feel any point, you mark yes or not, depending on what you find. Also, you have to look for the mobility of the ovaries. This is because we observed pain where the uterosacral ligament, you see, already you see a nodule here. So this is a painful point for the lady. But we don't observe any other site-specific tenderness, painful points. Okay. And then when you assess the site-specific, you move to the ovary to look for the mobility of the ovary. So the uterus is mobile, and then we look for the right ovary, mobile or not. So depending on what you find, you can mark whether the right ovary is mobile, or the same for the left ovary. This is the right ovary, which is apparently mobile. You mark it, and then you look for the left ovary in this case, in this example, and you assess the same. So the ovary is here, and then you go to the left ovary, try to look for the movement, the sliding, actually, mobility of the ovary. right there, and then you establish whether the ovary is mobile or not. You see, in this case, we consider that both ovaries were not mobile, which is a soft marker of the presence of endometriosis in the pelvis. And then you look for the presence of pelvic fluid, peritoneal cyst, or the presence of hydrosalpinx. There's no pelvic fluid, no peritoneal cyst, no presence of hydrosalpinx. All of these things you can mark it. Looking for the presence of hydrosalpinx, and we don't see any hydrosalpinx there, so you mark no. And then you go for the step 3. This is an anteverted uterus. We are looking for the sliding sign from the retrocervical area and the posterior uterine fundus. We are trying to find whether the sliding sign is positive or negative in the retrocervical area right there. Then you mark, and on the fundus and posterior aspect, you also is the abdominal hand over the fundus, and then you mark it. And this a little bit sliding, you see fixed. Sliding here positive, sliding here negative. So sliding side negative. And then step 4, looking for the anterior compartment, looking for the bladder. If you see any nodule there, you have to mark, looking for the ureter right there. This is the intramural part of the ureter here. Okay, this is the ureter. This is the ureter moving right there. Okay, both right and left ureters have to be assessed. And then you mark it. You see any lesion in the bladder or any lesion in the ureter, you should mark yes or no. And if you see any lesion, you have to measure. This is the contralateral ureter, looking for the movement of the ureter, the presence of any sign of dilatation of the ureter. You see dilatation, yes or not. Depending on what you see, you should mark yes or not. Here we are. Again, the ureter right there. Yeah, actually, this is already the parametrium, the lateral parametrium, which is the uterine vessels and the ureter right there. Here we are. These are vessels. You can use color Doppler. Yes, in case of doubt, you use color Doppler. You will see the filling of color right there where there are vessels, and you will see the ureter is not filling with the color unless movement of the urine inside the ureter. Okay, waiting for the movement of the ureter right there. Here we are, and then you should mark whether the ureter is involved or not. Again, reviewing the bladder, the trigonum there, base, and the dome here. And then you mark no in the anterior compartment. So no need to click on trigonum, bladder, base, or dome. The ureters are okay. And also the sliding of the uterovesical region to detect whether this area is obliterated or not. When we finish with the anterior compartment, we will look for the posterior compartment, and then we look for nodules. Here we have a nodule in the uterocycal ligament. On the left uterocycal ligament, you can measure it. So you click here, yes, you have the, not in the right, but in the left, and you can measure. you still look for another lesion in the posterior compartment, either in the bowel. Okay, we can see clearly that lesion in the bowel here, right there, and then you can measure it. This is the upper, so bowel deep endometriosis is okay, and then you go for the upper rectum, so you measure it. You have to scan the lower rectum, already scanned, and also the sigmoid. And you have to look the percentage of the circumference of the rectum involved by the nodule. So you need to take a transverse view, like of the rectum. And this is the lesion involving the rectum and the uterocycal ligament, the left uterocycal ligament. Okay, we are trying to follow. In this case, the lady has no bowel preparation before the scanning, so there's controversy regarding this is the sigmoid right there. And then when you have this all done, you have the complete report, okay, with the data of the patients, and here you see the whole complete report that you can get from this tool. So basically, this is a pretty interesting tool because it can guide you, because you have to follow all the steps. It's difficult to forget anything if you follow this protocol. Clearly, particularly for non-expert examiners, may be quite helpful for them just to have this tool implemented in their machines in order to perform a complete scan in a lady with suspected pelvic endometriosis. And you can see here, yes, a final review of all findings we have performed in this lesion. And then and here you have a new tool developed by Samsung, the so-called MB Flow, which is a much more sensitive tool to detect slow flow, which could means kind of changing paradigm regarding the assessment of the vascularization of the endometriotic nodules. You see here conventional power Doppler, two different lesions of the rectum right there, with conventional power Doppler versus MB flow. You can see clearly the differences. Actually, we perform a study with 30 cases. You can see that when you use power Doppler, about 87% of the cases you will have a score 1, 13% of the cases you will have a score 2. But when you use MB flow, regarding 3/4 of the cases, you will find a score 2 to 4. Particularly, 2/3 will have like a score 3 and 4. So clearly, this is a very interesting issue. Well, I'm done with this lecture. Thank you very much for your attention. I hope you have enjoyed, you have observed how you can use this protocol inbuilt in your machines, guiding and helping you to perform a scanning in a lady with suspected pelvic endometriosis. Thank you very much.
Many thanks for that very thorough run through. There's quite a few questions actually, as you've probably seen, so we'll try and get through those if you don't mind. Is that all right? So we've got Marco Zaccaria. Marco Zaccaria, where are you from? Avellino, I think you are, Marco. I think you work in healthcare equipment. I'm not sure, but that's what I think. Anyway, what about elastography in adenomyosis still? What do you think? Any experience, or what? We think it's got potential?
Well, Okay, thanks for the question. Actually, I don't have experience in using sonoelastography for assessing the uterus, so I can't talk by my own experience. But in my mind, theoretically, the uterus is very close to the endovaginal groove, so it's a good organ to be assessed by sonoelastography. And yes, I do think that probably, and in fact, there is some data on published paper in English literature that sonoelastography could be helpful for identifying adenomyosis, particularly discriminating between adenomyoma and fibroid, and also could be or could provide any information related to the potential response of adenomyosis to radiofrequency and so on. So I think that so far the experience is not so big, so large in the literature, but I think it's a pretty good tool for use in adenomyosis.
So we need some data, but you think the potential is there. It's kind of clinically plausible, isn't it, that it would be helpful? I think it's fair to say. What about AI? We obviously talked about AI. You're in your presentation, and maybe I'd just like to tie this conversation in with Ahmad's comment. Why should we use the software? It seems to be taking a lot more time than a regular scan. Well, okay. Kind of looking at both of those things. First of all, just applying the idea consensus and so forth in the machine. You can see Ahmed's point where he says, well, it seemed to take a long time. However, surely the point is that you do a complete examination and it's there in front of you. So you're doing a demonstration scan. So obviously you're taking quite a long time to do it. But I feel that having it on the machine like that means that you really are applying the idea consensus in practice. I mean, what's your feeling about that?
I absolutely agree with you, Tom. I mean, if you follow this idea protocol inbuilt in the machine, you are doing idea scanning protocol. So for research, for clinical practice, you are getting the information that you need to get using the idea protocol. So it takes time, obviously, because usually for most of the ladies with pelvic endometriosis, you need time to scan, to perform a complete scan. So, and I think that this is the interesting introduction of this idea protocol in the machines, and also for this, as I said in my presentation, because you have like a guide, is leading you on the way to scan completely. Do not forget any step, and looking for, because you are obligated to do that, looking for example, specific signs of adenomyosis, the size of the nodules. So I do really think that this inbuilt protocol could be very helpful for more sonographers. Yes.
Well, I think it goes back to Ligita's point earlier in her talk about it being useful educationally, because it helps you. And I think over time you will speed up in any event because you'll just get into doing it. But doing a full endometriosis scan does take a bit of time. It's not, some scans are quick scan, but they actually do take some time. I think it's fair to say. And I think it's an interesting question because obviously I don't know how many people are familiar with the addendum to the IDEA consensus published recently, but there's a question here about advances in imaging superficial peritoneal endometriosis. Have you got just comment a little bit on, just briefly on the features and where we are, because obviously you have talked about the idea and in principle looking at soft markers and nodules and so on. What about superficial endometriosis? Is it possible to diagnose it with an ultrasound?
In my opinion, to be honest with you, Toma, with the audience, years ago I was quite skeptical regarding the diagnosis of superficial endometriosis. Okay, but as all aspects in your life, when you learn to do that, when you are able to identify the lesions and you become more confident with the scanning, looking for and finally establishing the diagnosis of superficial endometriosis, I became to the conclusion that I become to the conclusion that you can diagnose superficial endometriosis. Probably you will not able to detect all cases. Probably you will not able to detect the whole spread of superficial endometriosis, but you will able to identify in some patients such tiny lesions on the superficial endometriosis. We don't have any idea about the learning curve. We don't have any idea about the correlation between ultrasound and laparoscopic findings. We need time, we need the studies, but I think that yes, we can diagnose superficial endometriosis.
So this was Mark Laufer. So Mark, I think there's a paper in the White Journal, which is an addendum to the IDEA consensus. I just draw your attention to that because it has some nice images of the features of superficial endometriosis, which I think would be useful to have a look at. I think talking about superficial endometriosis, somebody, I don't know the name, was just asking about identifying the uterosacral ligaments. Are there easy pointers? I mean, there are some nice videos around online you can probably find, but do you have any kind of simple advice on the best way to approach looking at the uterosacral scale?
Yeah, I would say that, okay, if you are able to identify the vaginal wall, which is gray, immediately behind it is the uterosacral ligament, white, in most of the ladies. So this is a very simple, gray, white, gray, white. So just to realize that you can identify this on the parasagittal view and in the transverse view. That could be very simple, but could be very helpful.
I find, and it might just be me being useless sometimes, especially when the uterus is, big fibroids, or you've got it's very retroverted, which of course you can get. Sometimes the position it makes it quite hard to see these things, and maybe it's just me not getting it right sometimes. But on occasion, I find that quite difficult. So this distorted anatomy, which of course is exactly when you get endometriosis. Sometimes I think it makes it a little bit more difficult than occasionally people say. I don't know, because I don't know what your feeling is about that, or am I just being incompetent?
No, not at all. But you are right. You are right, Thomas. Sometimes it's not easy because particularly there are some ladies with very tiny, very thin ultracycle ligaments, and it's very difficult to identify them. You're not sure regarding what you are looking at is really the uterocycle ligament, but in your mind you have to put the proof in the correct way. It's like when I train here people, I use a phantom just to train them how where is the point that you have to aim the endovaginal proof, because this is anatomy. If the anatomy is distorted, then you have a problem. But if the anatomy is not distorted by previous surgeries or whatever, the ligaments are there. So, but sometimes are difficult to identify.
Okay, so quick question. Yes or no? Is the standoff technique essential for DE diagnosis? You demonstrated some gel, I think, for you looking for deep endometriosis, but do you think you have to use that, or what's your practice?
In my opinion, it is not essential. Okay, but it's advisable.
Okay, so you don't have to, but it's worth trying. Okay. Blah, blah, blah. So what do you think about a simplified protocol for screening? Well, I think there's two questions, isn't there? Should you screen for endometriosis? And if you did, would you use the sliding sign and uterosacral ligament and upper rectal evaluation? Not as mapping, just screening. Well, I think that's a big question. I think it's probably more, I mean, if you're going to screen, I would guess that wouldn't be a bad way of doing it, but I would ask you whether or not screening is a good idea in any event.
Yeah, this is a very good question, actually, right? When you think in screening, we are focusing or we are talking about non-expert examiners. Most of people, I mean, expert are a few of them, but most are not experts. So if we think in a screening, that means that something wrong is there. I don't know what it is, but something wrong is there in the head of the fetus, the heart, the same. So particularly a simplified protocol and thinking on where are most commonly present the lesions could be a good idea. But my fear with this idea of a scanning, of a screening by just looking at the sliding of the uterus, and this is the step 3 or even the step 2, looking at the mobility of the ovaries, is that missing cases of deep endometriosis nodules without or with positive sliding signs and positive mobility of the ovary. So we don't know with the proper information on how many cases could be missing with nodules in the bladder, with nodules in the uterocycle ligaments, or in the sigmoid or rectum that have positive sliding signs. Positive sliding signs in a simplified protocol means normal lady, but the lady is not normal.
Yeah, but I
So
guess
that's
my
my fear
concern,
with that idea.
my concern would be, you know, just going back to WHO principles of screening kind of thing would be intervening in people where you find a nodule who, if your screening has minimal symptoms. I mean, the implications of, you know, over treatment and damaging people, I think, would be quite significant. I think it like, okay, but anyway, this is a conversation that could go on. Last comment, last question. You've been in the firing line. Excellent stuff. Just here, previous surgery. And I think this is really a good question, because my concern about some of these things, you know, these hyperechoic dots and so forth on the uterosacrals is, could that not happen with fibrosis, or do we always, is that how specific are these subtle findings for superficial endo? Could they be residual markers after infection or fibrosis after surgery, particularly in people who perhaps have, you know, had endosurgery before? I'm not, what's your view? Do we know enough about this at this time, or do we have to have a, you know, have a bit of a question mark there?
Another pretty good question from the audience. Clearly, in cases of previous surgery, previous infection, we can make mistakes when we scan the ladies, okay? Because we can, I think that the specificity of ultrasound scan drops when we have previous surgery or infections, because we see the same, not sliding, some hypoechoic nodules that could be fibrotic tissue related to the surgery, and it's not a new endometriotic nodule. So clearly, in those ladies, I would expect much lower specificity of ultrasound.
Okay, finally, a sort of existential question here. Do the uterosacral ligaments exist?
You know, Denis Kerle says that, which is a pretty good oncological surgeon. He says that the uterocycle ligament doesn't exist. It's just like a folding of the peritoneum, okay? So this is a discussion for anatomists, actually. In my opinion, you know, probably because I'm a little bit old, is that yes, clearly we do have some peritoneal fibrotic tissue. We identify pretty well that, in the laparoscopic surgery and on the open surgery. So in my opinion, yes, they exist. But as I told you, somehow there is a controversy regarding the real existence of a real ligament which fixes the uterus to the sacrum. That's true. That controversies exist among anatomists, among surgeons.
Excellent. Well, listen, I think we're going to have to let you off the hook at this point, Joel, before we get into some further philosophical discussions about the existence of mankind or something like that. Would be Right. That's a good question. It's a fair question because it is
It
asked.
is.
It is asked about uterosacral ligaments. I think, we could talk about endo for a long time. Great talk, JL. Many thanks. And thank you for taking so much time to answer all those questions. And it's great to have some
My pleasure.
engagement with all of you in the audience. Right, we're going to move on to some oncology now. So, Valentina, you've been waiting there, so thank you for waiting. Valentina Ciappa is from Italy at the National Cancer Institute of Milan. Amongst other things, she's worked previously many years ago, because obviously she's been running the show in Milan, but she's also been in Rome and I think also in Prague in the past. But she's an expert in the evaluation of patients with gynecological cancer. So quite a big topic we have for you, but we're going to talk about applications of ultrasounds in gynecological oncology, and then hopefully we're going to have some interesting questions, Valentina, so don't go away. I'll hand over to you.
Good afternoon, everyone. It is an honor for me to participate in this webinar, and I really thank Samsung for the invitation. Together, we will explore the possible application of ultrasound in gynecological oncology. In particular, we will take a journey through different gynecological conditions: adnexal masses, endometrial lesions, cervical cancer, myometrial pathologies, lymph node assessment. And for each topic, we will see how ultrasound could be useful. Let's start by evaluating the adnexal masses. The main role of ultrasound is to triage the masses between benign and malignant. This is important in order to choose between surgery and conservative management. In the case of surgery, it is important to evaluate between a demolitive or conservative approach, to evaluate the surgical approach if minimally invasive or not, and to select patients for fertility-sparing treatment if indicated. How can we assess the risk of malignancy in an adnexal lesion? We can rely on our experience, or we can rely on different mathematical models. The first task of the ultrasound examiner evaluating an adnexal mass is to be familiar with the IOTA terms and definitions in order to describe the different features of the lesion and to recognize the type of lesion. Each type of lesion is associated with a baseline risk of malignancy, which is important to know in order to formulate a diagnostic hypothesis for our patient. Among the mathematical models available, the Samsung Z20 ultrasound machine directly implements simple rules with the automatic calculation of the simple rule risk and the adnex model. As we can see, it is possible to directly click on the different rules that are satisfied to obtain a risk calculation. To apply the adnex model, we simply enter the required clinical and ultrasound features, and we immediately obtain the risk of malignancy. Now we are measuring the solid component. We select the number of locules, the presence of papillary projection, shadowing, ascites, CA125, and we calculate the risk. In case of a lesion suspected of being malignant, we have the stratification of the relative risk between borderline, early or advanced stage ovarian tumor and metastatic tumors. The second step in the ultrasound evaluation of adnexal masses is the assessment of the specific histotype of the lesion, which we call sonopathology. Again, the expert examiner can rely on his experience and identify the ultrasound pattern recognition of the different adnexal lesions, or we can refer to the literature. A fundamental tool is represented by the pictorial papers in the series Imaging in Gynecological Disease. Several papers have been published. Here you can see those related to the cases I'm about to present. In this first case, we see a unilocular solid cyst with anechoic content and a non-vascularized papilla with posterior shadowing. This appearance is typical of cyst adenofibroma, which presents with a hard papilla, generally color score 1, with posterior shadowing. The papilla we just saw is very different from the one we see in this case of borderline ovarian tumor. In this case, the lesion is multilocular solid for the presence of 2 locules and 2 papillae. The papillae have irregular shape and do not present posterior shadowing. So the papilla of the borderline ovarian tumor is different, is softer than the papilla of cystoadenofibromas. And above all, this kind of papillae have a vascularization that is generally hierarchical with the branches, as we can see in the middle with MV flow. Let's look at another case of borderline ovarian tumor with multiple and disseminated papillae. We tried to apply the ADNEX model by entering the required information, and as we can see, the risk of malignancy is significant, with the highest relative risk being for borderline ovarian tumor, a relative risk of 6.68. In this case too, the papillae show an irregular shape and they are vascularized. Let's now consider an interesting tumor histotype, the endometrioid ovarian cancer, which presents a different pattern recognition depending on the association with endometriosis. When the association is present, this tumor appears as a cyst with ground glass echogenicity and irregular vascularized papillae. When the tumor is not associated with endometriosis, it appears as a multilocular solid lesion and often presents the typical coccade-like sign with a solid tissue trapped between the septa. The solid tissue of the coccade generally appears vascularized, as in this case with color score 3. Here we can see a focus on the coccade with a 3D rendering that allow us to emphasize this particular pattern recognition. Unfortunately, we are not so able to recognize clear cell ovarian tumors for which there is no specific pattern recognition described. They can have an heterogeneous appearance. They can be unilocular solid, multilocular solid, or completely solid. In this case, the tumor appears as a unilocular solid lesion with anechoic content, vascularized papilla, two vascularized papillae that present posterior shadowing. In this case, it was very useful to identify a deep endometriosis nodule, this Indianette sign on the right, in the posterior compartment, as this tumor shows a strong association with endometriosis. Thanks to VSI and realistic crystal view 3D rendering, it is possible to emphasize the appearance of the papillae, and with MV flow 3D rendering, the hierarchical vascularization with branches. On ultrasound, the tubal cancers generally appear as tubular structures with incomplete septa and solid tissue that may partially or completely fill the lumen of the tube. In the upper case, the tumor appears as an elongated and unilocular solid lesion with papillary projections. In the lower line, the tumor is completely solid. In this example, we see a rare case of a clear cell carcinoma of the fallopian tube. Thanks to MV-Flow, we can appreciate the vascularization of the lesion in details, that is color score 4. As we can clearly see from the comparison thanks to the 3D rendering, the solid vascularized tumor is clearly different from the benign hydrosalpinx on the right. In this other case of tubal cancer, the solid lesion can be clearly separated from the ovary by applying a gentle pressure with the probe. We can see how the solid lesion appears richly vascularized with a color score 4, and thanks to 3D rendering with a realistic and crystal view and 3D rendering power Doppler, we can appreciate its appearance. We have seen how ultrasound can be used to predict the specific histotype of the adnexal lesions, which can be important in patient management. We know, for example, that certain tumor histotypes, such as low-grade serous ovarian cancer, are not very sensitive to chemotherapy. In these cases, therefore, having a preoperative suspicion can guide the surgeon toward a more cytoreductive effort. Through ultrasound, we can also try to describe the abdominal spread of disease in patients with ovarian cancer and predict the possibility of complete cytoreduction. In recent years, Daniela Fischerova has coordinated a multi-center study called ISAC, which aimed to demonstrate the non-inferiority of ultrasound compared to whole-body DVI MRI and PET-CT. Considering the different sites of disease, ultrasound shows the best AUC on the omentum and pelvic peritoneum assessment. A slightly lower performance for parietal peritoneum, diaphragm, lesser omentum, spleen, liver, and lymph nodes, and the worst performance in the assessment of mesentery and bowel serosa. However, overall, ultrasound have proven to be not inferior to the other imaging modalities for predicting the non-resectability of the tumor. So, this is a race we can play. But how do the different tumor histotypes appear on ultrasound? Here, we can see some examples of peritoneal localization of ovarian cancer visualized by transvaginal ultrasound. In this first case, the carcinomatosis is at the level of the pelvic side wall, with these vascularized nodules with irregular shape. In the second case, it is a peritoneal carcinomatosis at the level of the Douglas patch, emphasized with 3D rendering with the crystal and realistic view. When we study the endometrium using ultrasound, it is now clear that the thickness is not sufficient. We must be familiar with AITA terms and definitions, and we must learn how to describe the endometrium from a qualitative point of view, evaluating all these features. In this case, we can see a non-homogeneous endometrium due to the presence of regular cystic areas. The midline is not visible and the endomyometrial junction is regular. The presence of a focal lesion is not clear. Then we proceeded with the placement of an intrauterine catheter and inject saline infusion to perform a hysterosonography. This clearly enhances an anterior polyp, that is a focal localized lesion. The Samsung Z20 ultrasound machine directly implements AITA terms and definitions, allowing us to proceed directly by selecting the various characteristics of the endometrium and endometrial lesions, as in this case of an endometrial polyp, which is described as a localized focal lesion with a bright edge. Here we directly measure the lesion and the diameters are recorded, bright edge is present, the echogenicity is uniform, the outline is regular, the lesion is completely endocavitary and localized. In the case of endometrial cancer, we can proceed with describing the characteristics of the tumor and with local staging of the disease, assessing the extent to the cervical stroma, myometrial infiltration, and adnexa and lymph node involvement. I will now show you some cases of tumors. In this first case, the tumor is mainly isthmic and it causes hematometra. With 3D power Doppler rendering, we can clearly highlight the vascular pattern of the isthmic tumor. In this other case, the tumor occupies the entire uterus, deeply infiltrating the myometrium and the cervical stroma. Vascularization is rich, with color score 4, with multiple vessels of multifocal origin, as we can see with the power Doppler on the left and ENVU flow on the right. In this case, we see an extremely non-homogeneous endometrial lesion with regular and irregular cystic areas that completely fill the endometrial cavity without any apparent infiltration of the cervix and with the endomyometrial junction apparently regular. This was a rare case of uterine carcinosarcoma arising on a large endometrial polyp, as we can see on the macroscopy specimen after surgery. When we examine cervical cancer using ultrasound, we will first identify and measure the tumor, and then we will proceed with local staging of the tumor. In accordance with ESGO recommendations, ultrasound performed by an experienced examiner is an alternative option to the MRI. We will therefore describe the tumor size, its qualitative features, and we evaluate the anterior, lateral, and posterior parametrial involvement. The first step is to recognize the presence of the tumor and measure it in the 3 orthogonal planes. A squamous cellular cervical tumor usually appears as a solid hypoechogenic lesion. Ultrasound evaluation with Doppler can help us to identify the tumor, as the tumor is always richly vascularized with color score 3 to 4, as we can see with power Doppler. Through 3D power Doppler rendering or color Doppler rendering, it is possible to obtain a realistic assessment of the vascular pattern of the lesion. The introduction of saline solution into the vagina performing a vaginosonography can also help us to better highlight the tumor outlines. Let's now proceed with the evaluation of parametrial infiltration. We proceed by positioning the probe in the anterior fornix. We check the bladder and we move laterally to check the ureters. Then we apply a gentle pressure with the probe and we evaluate the presence of the anterior sliding sign at the level of the vesicouterine space and septum, as in this case on the right. In these two cases, we visualize the presence of a suburethral nodule on the left and on the right, the absence of the sliding sign and the infiltration of the bladder wall. Then we rotate the probe of 90 degrees and we evaluate the lateral parametria. In the case on the left of the screen, we see a grade 2-3 parametrial infiltration with solid macroscopic spiculae protruding into the pericervical tissue. On the right side, we see metastatic parametrial lymph nodes that are defined as grade 4 infiltration or skip metastasis. We then move the probe into the posterior fornix and we evaluate the posterior parametrium by applying a gentle pressure with the probe. In this case, the sliding sign is present and regular. In the two cases that I'm presenting now, we see a macroscopic infiltration of the posterior parametrium in the case on the left, and on the right, a massive infiltration of the rectosigmoid wall, a full thickness infiltration. We can also assess parametrial infiltration using 3D ultrasound, making a cut perpendicular to the craniocaudal axis of the cervix and navigating through the volume. This provides a very similar assessment to that performed by the radiologist with MRI. One of the most difficult ultrasound evaluations in gynecological oncology is the differential diagnosis of myometrial lesions between myoma and sarcoma. Typical myomas generally show a regular capsule, posterior shadowing or edge shadowing, absent or poor vascularization with color score 1 or 2, predominantly capsular vascularization, and they are frequently multiple lesions. A few years ago, we tried to identify a pattern recognition of uterine sarcomas with poor results, as we understood that these are extremely heterogeneous lesions. We must be suspicious in the presence of large single lesions with irregular margins, non-homogeneous ecostructure, absence of shadowing, and increased vascularization, especially if intralesional. I now show you the case of this single, large, heterogeneous uterine mass with irregular cystic areas. The vascularization of the lesion was rich, with the color score 3 to 4. The 3D rendering reflects very well the heterogeneity of the mass when cut after surgery. The 3D rendering on the left and the macroscopic specimen on the right. Our final topic is lymph node status assessment. Metastatic lymph nodes show disappearance of the nodal core sign and disordered transcapsular vascularization. We can evaluate the pelvic lymph nodes along the iliac vessels, as in this case, in which we can see multiple oval-shaped metastatic nodes. We can do the same for the para-aortic lymph nodes, as in this case of tubal cancer, where we can see two round-shaped metastatic lymph nodes. With the linear probe, we check the groins. In this case, we see an irregular pathological lymph node with disappearance of the core sign and the hyperechoic perilymph node halo. In this case, the lymph node is round, irregular, with a reticular pattern, a hyperechoic perilymph node halo, and transcapsular enhanced vascularization. In this case, we perform the fine needle aspiration directly during the ultrasound examination, with the diagnosis of localization of a B-cell lymphoma. I really thank you for your attention.
Thank you very much, Valentina. Could we just stop sharing, Samsung, if you're there? Earth to Samsung. Anyway, Valentina, thank you very much for a great presentation, covering an awful lot of ground, I have to say. Not easy to get through all of that in about 25 minutes. I'm just looking here to see if we have any pictures, any questions. I'm just going to address one question, which is about the availability of the Adnex model online. And I think I can answer that if that's okay. And the answer is it's not available online at the moment. It's available on the machines, or some machines, including Samsung. And the reason it's not available online is the introduction of medical device regulation in Europe, and it's a change which I think is quite a profound change, actually. I don't know what the panelists think, where mathematical models now become medical devices and require really quite onerous regulatory approval, and so which is also very expensive. I mean, about 100,000 plus euros. So we've been taking Adnex through that process, and it should be available online in the next, certainly, hopefully September, October, within the EU and other places afterwards. But you can use it on the machines. But that's why it hasn't been available, but it will be available soon. Right, I just thought I'd get that out of the way, Valentina. I hope you don't mind. So I just noticed at the end there you're using FNA for lymph nodes. I might use a different topic, but I just thought it's something, given the fact you're talking about oncology, whether you might have a comment about true cut biopsy and when you use it, because people often talk about biopsying or and so on. What are the indications for true cut biopsy? Is it sort of potential recurrence and solid masses, things like that? Where do you see its role?
Yeah, thank you for the question. It was a topic I would like to include in the presentation, but the time was too short time. I think
Yes.
we perform fine needle aspiration or true cut both directly during our ultrasound examination. We prefer using transvaginal true cut biopsy through transvaginal or transabdominal evaluation. For lymph nodes, it depends of the dimension of the node. If it's a very small node, we prefer using a fine needle aspiration. If for the nodes you have seen, we could perform also true cut biopsy. I think true cut biopsy is a very important option for fragile patients with a suspicion of disseminated oncological lesion. For example, if we think that the patient cannot undergo an optimal cytoreduction, we perform true cut biopsy, and in few days we can start neoadjuvant chemotherapy. Of course, true cut biopsy it's not an option when we have a single lesion in a new oncological diagnosis. If the patient come to my attention with a single pelvic lesion without any spread, we prefer to undergo surgery. The only option the only case is a very fragile patient with a possibility to severe complication during or after surgery. Of course, true cut biopsy can be performed for recurrences, pelvic, peritoneal, omental, nodal. We can perform biopsy of many sites with a few complications. We've seen that the most frequently complications are bleeding, infections, but are very, very rare. Even the perforation of bowel loops is very rare, and usually the patient has no any consequence after the biopsy. We do not need to keep the patient in observation for a lot of time. Usually we perform the true-cut biopsy with just a blood exam. We check the hemoglobin and coagulation. We perform the biopsy and we keep the patient for about 1-2 hours after the procedure, and then she goes home.
Okay, just moving on. There's a sort of straight question here about, do you prefer MV flow or power Doppler, or what's the difference, I guess? I mean, what are you, that's a loaded question on a Samsung webinar. Go on.
It's okay. So usually in gynecology, we do not need the direction of the flow. So I do not use color Doppler. I use power Doppler. Usually it's very important to correctly set the Doppler. The PRF should be 0.4, 0.6. And it's okay. Now we have the possibility to use MV flow. We know that tumors show neoangiogenesis, so MV flow is more sensitive for very slow flow vessels. So we can better reconstruct, for example, the vascular pattern of the lesions in cervical cancers, but also in ovarian lesions. We just be careful not to overdiagnose vascularization with MV flow. So it's very important to correctly set the evaluation, as Juan Luis showed before for endometriosis. But I think that if we decide that the lesion is color score 1, both with power Doppler and MV flow, it's really a color score 1. We are sure that papilla is not vascularized. So for very small lesions and papillae, I use MV flow to be sure that there's no vascularization inside.
So it allows you to dichotomize it almost. I always think with the color score, in reality, it's got lots of it or none, and then in the middle, I'm never quite sure, to be honest. But anyway,
Yeah.
I think the Gita, certainly in Malmo, in Lund, you looked at vascular pattern, didn't you? I think, was that you? I think. And I suppose one might argue that MV flow may allow more details of vascular patterns. Perhaps, I don't know any data on that, but is that somewhere where you feel, I don't know, am I picking you out unfairly, Gita? But I certainly know that I think you published on that, haven't you?
Yes, that's true. We published on the vascular tree where we looked at the vessel morphology, and it was quite a while ago. So we used not that very advanced ultrasound machines. We used power Doppler. And of course, power Doppler at that time was the best to detect vessels with low velocity because of the neoangiogenesis we have at particular vessel branching, not dichotomy branching, and we also have so-called splashes because of neovascularization, and these signs were more common in malignant tumors than benign. But with MV flow, we can reach even more tiny vessels with lower flow velocity. So I think this is another step into detecting more vessels. So I think MV flow is more sensitive and of course better to use than just the power Doppler, I think.
I think it might be quite interesting in areas like fertility and so forth, looking at endometrial, vascularity, because we always was looking at endometrial receptivity and so on. So I suspect quite a lot of areas will have to be revisited, perhaps, to see whether or not it's actually of any value.
Yeah, I would just add that, of course, if we are after detecting the vessels with low velocity, we also increase the risk for the artifacts. So there's a balance.
Yeah.
We should be very, very
Well,
careful not to go too low to PRF and not to go too low to PRF. Yes, but again, in low velocities, MV flow is very good, but in high velocities, it will not be that informative.
Well, I think the thing is with all new, I mean, this is about innovations in ultrasound, and I guess I'm sure we'd all agree that JL and myself, I'm not going to speak for John because he's a young man of about 35, aren't you, Juan Luis? Yes? JL, you're about what, 35 years old? He's not even, in fact, he's old, he can't hear me.
Sorry.
I was saying you're about 35 years old, aren't you? Yes.
Yeah. I'm like that. Yeah.
Anyway, you and I can remember that when you have innovations in ultrasound, you've got to be a bit careful because you see more stuff, and sometimes that can lead to overdiagnosis and misinterpretation. And every time there's an innovation, everyone goes, there's a well-known curve, where everyone thinks it's amazing, and then everyone says it's rubbish because and then it finds its place, basically. I think it's the Gautner curve or something, and we've all seen it many times. And it's just important to be realistic and not over. I think when people oversell something when it's new, most people, I think doctors by their nature are quite cynical, or should be, and they kind of look and then they just dismiss it. And then actually there is a role for some of these things, but it takes time for it to find its place, I think. Anyway, that's something I've observed over time. I'm sure we all have. So Valentina, going back to you, I'm just interested about this issue about staging endometrial cancer. Are there situations where that can be difficult? I sometimes worry when you have adenomyosis coexisting and fibroids that it's when I'm in lectures it always looks very nice and easy, but I'm not sure it always. Again, a question I said to JL, really, it's not always that easy, I think. And what's your observation, or what sort of cases sometimes do you find it difficult?
Yes, not. There are some conditions that impair the ultrasound staging, of course, fibroids, adenomyosis, but also we have some particular spreads of endometrial cancers, such as MELF pattern. So the tumors spread not as a unique lesion invading the myometrium, but as single glands protruding into the myometrial up to the serosa, and we cannot recognize this type of infiltration. We think it's an early stage tumor, but after surgery it invades up to the serosa. Adenomyosis is difficult. It's a difficult condition. But few months ago, I studied the correlation between adenomyosis and cancer, and I found in literature two different conditions. When the tumor is associated with adenomyosis, adenomyosis often is a barrier to myometrial infiltration. So these tumors are more frequently in early stage tumors. There are very rare cases where the tumor arises into adenomyotic glands, and this is a different condition. The tumors has an early spread through blood and lymphatic routes because it has not it has a thinner wall, myometrial wall up to the serosa.
So there's always exceptions, aren't there, where it's very, very difficult. There's a couple of questions. I'm mindful it's now 2:00. So very quick answers, if you wouldn't mind. Does some people are keen on elastography? Cancer of the cervix, any experience? Yes, no, maybe. Fairly short answer. What do you think?
We tried it in our experience for research purposes, but I've seen that there's no difference with a classical conventional ultrasound, because the tumor is very vascularized, so it's always well detectable with power Doppler, and so you don't need the elastography to check and to recognize the tumor. And even for parametrial infiltration, you just have to recognize the spiculae protruding into the tissue. It's quite easy after a learning curve of some cases.
Okay, that's enough. Well, I think this is a good one to finish on. How close to histological staging can newer machines predict? Well, I think actually in reality you can often have a pretty good idea of what the histology of a lesion is actually from ultrasound and the patterns. But at the end of the day, it doesn't replace it. But I would ask the question of you: how do you differentiate? What is your position on endometriomas with desidualization during pregnancy, and how you manage or can you tell the difference between those? And they've said in the question papillary cyst adenomas, but I would say borderline or early stage cancer.
Yeah, because this differential diagnosis is okay because they are both benign lesion. Of course, it's very important the history of the patient. If she has an history of endometriosis before pregnancy, we can focus on the decidualized endometriomas. The papillae are usually round with the regular shape. They are often vascularized as for borderline tumors, but borderline papillary projection are more irregular, and you can see this microcystic pattern of the papilla that usually the decidualized endometriomas don't have, and also cystoadenofibromas. Cystoadenofibromas has a hard papilla, not vascularized, with posterior shadowing.
I mean, I must say, even if we worry, you know, because I mean, obviously it's helpful. I mean, if they've got a scan pre-pregnancy with a cyst that's with an endometrioma, then it's not,
It's very
and there really is no concern, and you take the view that it's a decidualizing. We tend to be more and more conservative, even with patients who we think may have a borderline, actually, if it's relatively late in pregnancy. I mean, it's quite a debatable area at the moment, isn't it? I think it's a more conservative management. And in our unit, I think we're pretty conservative about intervention, and quite often we pretty well known it's borderline, but then waited for the baby to be delivered and then sourced and then operated. I don't think it's quite so like that in Italy. My impression, listening to you.
I think if the patient has an history of borderline, so this is almost certainly a recurrence, we can wait. The patient can undergo, we perform during pregnancy a scan every 4 or 5 weeks to check the lesion. But if it's the first appearance of an ovarian lesion, we need, of course, an histology, because sometimes borderline are very similar to early stage ovarian cancers. So we perform surgery during the second trimester between 12 and 18 weeks.
Perfect. What I would say to the question is that IOTA, like Adnex, hasn't been validated in pregnancy. And I think given the problem with decidualization, I think we're all aware that the decidualization is likely to cause false positive test results with Adnex because of papillations. So, but anyway, there is a big project called P-IOTA ongoing at the moment, which is recruiting patients for that. I think the other big area of ovarian mass is where we're doing a study, but I think will change. I think is a huge area actually, is the management in young people. I think a lot of young, getting the diagnosis right in adolescence and young women is so important, because certainly in the UK, they often go to non-gynecologists sometimes, and they end up having surgery and losing their ovary for no reason. Just wondered if you have any comments on that, or what everyone else's experience is. Because in fact, intervention in pregnancy is such a big deal, and intervention in young. I'm not saying it matters; it always matters, but I think the care isn't so great in some of these younger women sometimes.
Yeah, we see many children in our institution, and surgery is performed both by a pediatric surgeon and a gynecologist, because we have seen that the gynecologist is more careful to preserve fertility. So
Perfect. You're going to get an email from Nina Cooper asking you to recruit to my IOTA. Please do so. We're going to have to end the webinar now, not because it's not interesting, not because we couldn't have loads more questions, because it's been a really enjoyable couple of hours actually, with some big topics for all of you to cover. So I'd just like to thank the audience, first of all, for being there and being engaged and sending lots of questions through, because there's nothing worse than giving a talk and then everyone just sits there and no one asks a question. So it's so thank you for that. Particularly, I just want to thank the three of you, Valentina, Ligita, and JL. Thank you so much for giving up your time. I know that it's not just the time on the webinar; it's all the time to prepare the lectures and in fact all the work that goes behind that. You're not just getting a 1-hour lecture; you're getting often 20 years of work going into 1 hour of lectures. So I think people often forget that when people are asked to speak. There's a lot of work goes into it. So thank you, all of you, real experts in your field. And I think it's just illustrated today how things are changing. There are new technological innovations coming through. As Ligita said, these have to be carefully evaluated, and must sure we know their limitations as well. But I think these are incremental changes that generally, I think, add to diagnostic performance. And I think JL showed very well, and Valentina also, how these sort of integrated reporting systems are now coming into machines, which I know at first sight seem to look quite labor intensive, but I think they mean that we will scan in a much more repeatable, reproducible way, that once you get used to it, actually you speed up a lot. And I think that way you have a much more complete examination. So until the next time, I'm going to hand back to June, who hopefully by now has been on some kind of second webinar teaching him how to unmute his microphone, so he'll get it right this time. June, are you going to say goodbye to everyone? Over to you.
Yes, I will. I've got it correct this time. Okay, thank you very much for that. We'd like to once again express our sincere appreciation to our distinguished speakers, Ligita, JL, Valentina, and you, Professor Tombor, for moderating this webinar. And it's a pleasure to announce our next webinars, which is scheduled for August the 17th, titled The Fetal Brain Anomalies. We hope you'll join us to another thoughtful, provoking, and educational session. We're also excited to share that Samsung will be participating in ISWA Cancun, and we hope to see you there. And more information will be available on our official website and social media channels, so we can be to share our interesting academic events there. Before we close today's session, we greatly appreciate if you could take a few moments to complete our feedback survey. Your input is invaluable in helping us create even better webinars in the future. A recording of today's webinar will be made available. Please keep an eye out for the playback link. And with this concludes today's webinar, and I thank everyone for joining this wonderful event. Thank you very much, and hope to see you again soon. Thank you.